Hi everyone, let's study about BPH, benign prostatic hyperplasia, which we can say as a mnemonic big prostate hurts. Big means enlargement, we can say that prostate is enlarged. Prostate in which area? That most commonly in the transitional zone. Hurts, where does it hurt? In lower urinary tract, okay? It gives lower urinary tract symptoms. Definition: a non-malignant enlargement of prostate gland, primarily arising from the proliferation of glandular and stromal tissue. It may be glandular or it can be stromal. It depends on epithelium or smooth muscles toning in a periurethral transitional zone. So this is a prostate which gets enlarged, which can cause decrease in the lumen and increases the curvature here, which adds the difficulty to add catheter. Etiology and pathophysiology: stromal hyperplasia due to 5-DTH, when testosterone gets converted into 5-DHT. Fifth decade of life, it mostly occurs in the fifth decade of life in old male. Increases in estrogenic steroids from the adrenal cortex may disrupt the DHT local peptide growth factor imbalance, as it disrupts the DHT local peptide, which releases cytokines and growth factors such as IGF, FGF, interleukin 8, interleukin 7. Pathophysiology: BPH causes nodular hyperplasia in the transitional zone, which leads to urethral compression, and it gives bladder outlet obstruction, and which leads to lower urinary tract symptoms. Clinical features present in men over 50 years with symptoms. There are two kinds of symptoms: obstructive and irritative. Obstructive LUTS: hesitancy, poor stream, intermittency, terminal dribbling, incomplete emptying, acute or chronic urinary retention, which can be presented as a mnemonic. BTR, it is a BTR mnemonic HWIM for obstructive hesitancy, weak stream, intermittency, and no feeling of a complete emptying. Irritative LUTS: frequency, urgency, nocturia, urge incontinence. Prostatic urethra: as I said, it decreases the lumen due to obstruction, which leads to LUTS features, and curve increases, which increases the difficulty to catheterization in the patient. Obstruction in the prostate: obstruction increases pressure in the bladder. Diverticulae and trabeculae: increases residual urine in the bladder. This is a very important score, International Prostate Symptom Score. If there are more symptoms, then it can be classified in a different kind of severity. Can be moderate, severe, mild. If the score is between 0 to 7, it is considered as mild, and its management is just observation. 8 to 19, it's moderate, and 20 to 35 is a severe, and its management can be medical or surgical. Now, investigation. First of all, we take history and symptoms and scoring IPSS to quantify LUTS severity. Physical examination, digital rectum examination is carried out to assess the size, consistency, and nodularity of the prostate. Then there is urine analysis to rule out infection, that is UTI and hematuria. Now, PSA, it's a very important test. It is that is prostate specific antigen. It is elevated in BPH but also in cancer, infection, or trauma. Normally, it is less than 2.5 in 40 to 50 years of age male, less than 3.5 nanogram per milliliter in 50 to 30, less than 4 to 5 nanogram per ml in 60 to 70 years, and less than 6.5 in more than 70 years. Euroflowmetry peak flow rate is less than 12 ml per second. Indicates obstruction. If it is less than 12 ml per second, then it indicates obstruction. Then post-void residual, PVR, ultrasound to measure bladder emptying. If the residue is more than 300 ml, such as retention. Imaging. we have to carry out a USG, that is transrectal ultrasound for prostate volume, and renal ultrasound for upper tract dilatation due to hydronephrosis, urodynamics, and then other urethroskopy, biopsy of PSA, digital rectum examination suspicious of cancer. Then there is management. There are two types of management: medical and surgical management. Medical management, we can give alpha 1A selective blockers, which are quick in action, or 5 alpha reductase inhibitor, which has a delayed action. 5 alpha 1A selective blockers, that is tamsulosin, alpha-sosin, terazosin, prazosin. Then 5 alpha reductase inhibitors are finasteride and daptasteride. Alpha 1 selective blockers action is to decrease smooth muscle tone, and in 5 alpha reductase it is to decrease stromal hyperplasia. Side effect: the first dose it causes postural hypotension, and in this it causes erectile dysfunction and decreases sexual drive. Surgical management, its indication: hydronephrosis, retention of urine, gross hematuria, bladder diverticuli, flow rate is less than 10 ml per second, pressure is more than 80 cm H2O, or UTI, etc. Now, types of surgery. There are 4 types of surgery that can be carried out: transurethral resection of prostate, which is a gold standard, then holmium laser inoculation of prostate, then transurethral laser incision of prostate, and open or retropubic Millin's prostatectomy. These are the older methods. First one, TURP, HOLEP or TULIP. What is done in TURP? The instrument that is used is resectoscope. Laser that is used is hemostatic, and it causes faster surgery. NT-YAG most common. KTPA best, green light, that is 532 nanometer. Irrigating fluids. Which irrigating fluids are used? 5% dextrose and distilled water. But these two are hypotonic, which increases the risk of TURP syndrome, which I'll be explaining in later. Isotonic glycine, which is 1.5% most common and best. It causes a less TURP syndrome and normal saline. Complication: first, hemorrhagic. Hemorrhagic, how? Because there are vessels present, such as a bed notch arteries most common, and Folch arteries. Second, fluid retention. Foley's catheter is used for that. Then water intoxication, dilutional hyponatremia, or TURP syndrome, which I have talked about before. Because of a 5% dextrose and distilled water, there is a occurrence of a TURP syndrome. Then glycine toxicity, retrograde ejaculation due to bladder neck injury. And lastly, strictures and incontinence due to resection past verumontanum.